Alright, welcome to our C-arm course. This is Bob narrating and we have Dave demonstrating. Dave's in front of an OEC 9800 Plus, a GE C-arm, and we'll be using that for our demonstration purposes. So every C-arm has two major components. One is the source from which your x-rays come out of. That's located at the bottom. And the other is the detector, where your x-rays are detected after they've gone through your patient's body. They come out from the source in what looks like a cone shape as they extend towards the detector. So you can picture a giant dunce cap turned upside down. It's all coming out from a pinpoint and it's making a cone. To recap, we see our x-ray tube, our beam coming out and diverging. It hits our patient, it keeps getting bigger, and then it ends up on our detector. Okay, so now we've talked about how our x-rays come out of the bottom, and here we are in a standard anterior to posterior projection. Our patient is lying face down. And so in this position, most of our scatter, the beam comes out of here, most of our scatter is bouncing off the first surface the x-rays hit. So most of our scatter hits the bottom of this table and bounces back down. So standing under the table would be a bad place for you to be. The doctor's in a relatively good place because most is going back down and they're working up here. The nurse off in this corner, the further away they are, the better. They've got both a scatter event off the bottom and off the floor before we get to them. And with distance, your intensity decreases. So the further you are, the less intense it'll be. So what you do want to remember is face forward with your apron because the scatter is coming this way. If you face backwards, you're not covered. Okay, so this is a relatively safe position for the nurse, very safe for the tech, and safe for the doctor's eyes and hands. Okay, so here we are in our lateral position, and this is the position where the doctor, if he's standing where I'm standing, he or she is getting their most dose. Again, my x-rays are coming out here in a cone, and the first surface they hit is the patient, and it bounces straight back at me. Okay, so the dose is much less over here, because most didn't get through the patient, most didn't get through our camera, and then this is all extra protection. But for the doctor, he's got the most dose here because it's bouncing straight off the patient at him. If I brought this tube up even higher, it would not only be the highest dose, the scatter would be above the table, and it would be bouncing back at my eyes. So the other thing I want to tell you in this position is you want to keep your source as far from your patient as possible to limit the dose to your patient. We've been mainly talking about the scatter off your patient or your equipment and limiting the dose to you, the radiation worker. But it's important when you do the lateral to keep your source as far from your patient to minimize the dose to your patient as well. Okay, we're back in our AP. X-rays coming out through the front of our patient, out the back to our detector. One way to minimize dose to your patient is keep your detector as close to your patient as possible, which means your source will be as far away as possible. Now remember, you do have to give your doctor some room to work here, so you can't go all the way down. Sometimes maybe 5 inches will be enough. It depends on the procedure. Now, when you go to the oblique, when you're obliqued in this direction, again, most of your x-rays bounce off of here and come back straight 180. And so more of your x-rays are going to be scattering towards the doctor's side of the room and less towards the tech. But all your x-rays are bouncing around under the table, not shooting up towards your eyes. And when you go to this oblique, now the doctor's side is a little safer, while the tech side is getting more of the scatter back radiation. Another way to save dose is not take another picture. One of the features of the C-arm is you can change the contrast and the brightness of your picture without taking another picture, and sometimes that'll help you demonstrate and answer the question that you're trying to see without exposing your patient yet again. so another way to save dose is limit the amount that comes out of the source. And we can do that by collimating. Here's a picture with no collimation, and then I can bring this small circle in and just focus on the region of interest, and I get a better quality image, better contrast at a lower dose, and I've also reduced the amount of area that I've let the X-rays free in. Another way to collimate is we can collimate as slats, 2 slats, if that's more appropriate for our picture, instead of 2 circles. And so like the slats and the circles, it's a way to protect your doctor's hands, because you might be able to keep the region of interest present but keep their hands out of the picture. Less radiation gets out of the tube, less radiation has the chance to scatter and get to you. Here is a useful figure. On the left we see I've collimated, so I only have 50% of the field of view, and the monitor would show that collimation. And on the right, I've got no collimation, so the monitor shows 100% of the field of view. These are ISO exposure curves showing the radiation exposure outside from the X-ray tube. And you see right near the tube, I am down to 1 milligray per hour when I've collimated versus 2 milligray per hour when I'm uncollimated. So I can greatly reduce the scatter by collimating. When taking a movie, or fluoro, or cine, all the same thing, you have 2 options. You can be in continuous mode, where the motion will be rather smooth. Here is a demonstration of continuous mode as I rotate. The motion is rather smooth, and continuous means the radiation is coming out the whole time. The other mode you can do, which saves dose a lot, is you can put it in a pulse mode. And now, rather than having the lights on continuously, it's like you have a strobe light. So motion appears stuttery. Your image quality is sacrificed and your motion is stuttery. But you are saving an incredible amount of dose, because rather than having the lights on continuously, now you're just strobing the X-rays with short little pulses of intensity. So here we are with the least possible dose, because the detector is crazy close to our patient. And that also does the least magnification. But you don't have enough room to work. So as that source gets closer to our patient and the detector gets further, we magnify our part more and more. So one way of magnifying your part is just changing the detector position and your patient position. But as I said before, we want to keep a minimum distance from our patient and reduce the amount of dose to our patient. Another way to change magnification is on the unit itself. We've got our 9-inch mode, which is shown here. We can magnify to a 6-inch mode, as shown here, and we can go even further to a 3-inch mode. But each time we increase our magnification, we increase our dose to the patient. So nothing is for free. So when you magnify and zoom in, you pay for it in dose. Okay, I wanted to talk about finding some landmarks, because you're going to be labeling the patient right or left, and you're going to be doing it for different disc levels. So there are some landmarks that are easy, and from those you're going to count up or down. So if you put your hands on your hips, then you're on your top of your crest, and that's right even with the bottom of lumbar disc 4. And as you see from the picture here, here's lumbar disc 5, here's lumbar disc 4. So a lot of times, even with the top of your crest is even with lumbar disc 4. So if we go to our patient, Liz, thank you, I can feel along her hip line, and I can find the top of her crest, and I'll say, aha, this is L4. So if my exam is at L3 or L2, about 2 fingers per disc. Here's L4, here's L3, here's L2, here's L1. I can go up or down, and I can count. A lot of times we're looking for T12, the last thoracic rib that has disc that has ribs coming off. The other landmark we often look for is our cervical our last cervical disc, which is C7. And that has the bony prominence that juts out at the back of your neck. So finding the biggest jutting bone at the back of a patient's neck will let you say, aha, this is C7. And then you can count up to C6, 5, 4, 3, and it might be just a finger for each of those. Or you can count down for the thoracic. There's 7 cervical, 12 thoracic, and 5 lumbar. You can think you have breakfast at 7 a.m., lunch at noon, and dinner at 5. Other areas you might find is the SI joint, and that's right even with the top of the crack of your butt. And let's see, those points should help you get everywhere, and the hip joint. For the hip joint, you often might have your patient bend the knee and then look at that crease that's formed when their leg is up. And you can do this on the side that doesn't hurt, and then you can just parallel it to get to the side that does hurt. So that should be helpful for marking the spot for laterality, right or left, for routing your EKG leads so that they don't interfere with the exam, and for prepping your patient for a nice small disinfected area. Okay, thank you, Liz. All right, I want to talk about respecting your lead. It's here to protect you. It protects you in the front. It's not protecting you in the back, so make sure to stay facing forward. On your lead, you're going to have a dose badge, and the dose badge itself is going to be constructed and designed specifically as either a collar dose badge, or a chest dose badge, or perhaps even a waist dose badge. And the calculations that are made off of the dose collected on your badge are made based on it being worn at the appropriate position. And so you're always wearing it outside, except for a pregnant radiation worker. They'll have more than one dose badge, and they'll have one dose badge that they wear inside their lead to represent the dose that the unborn child might be getting. And then they're going to also wear probably a waist and a collar dose badge outside their lead. All right, respect the lead. So here comes my lead. I'm done for the day. I make sure to take my badge off. And I'm going to hang it up, and I'm going to hang it up carefully so that there are not any folds. This is lead, and the way these aprons die is they get folded and a small crack forms, and that crack lets radiation through. Every 6 months or every 12 months, they're checked for cracks, and the ones that have cracks get thrown out. So it's important to hang them up, hang them on the bar, hang it so it's not folded. I don't want to ever see this. Oh my God! Alright, so hang them carefully so that they have a nice long life. Alright, thank you. This is XRayBob, out!